if you don't find yourself standing next to a resident putting in a central line or even an ultrasound guided IV saying, show me your needle tip, show me your needle tip, then you don't really know what you're doing with ultrasound guided procedures. That is the key to doing this procedure, to doing a central line, or really anything with ultrasound, is knowing where the sharp end of your needle is and being accurate with where you place it. So we won't talk about the anatomy of ultrasound probe, you guys know, but we will talk a little bit about the anatomy for the upper arm. Typically, our nurses have done a good job looking in the forearm, hand, AC fossa, and they've stabbed the patient a few times, and then they come to you and they say, hey, we couldn't get a line, doc. And so that's where ultrasound IV access really shines. Really going to highlight the basilic vein. It's superficial, it doesn't run with an artery, and it's just a big target usually to aim for. So here's our brachial vein. In this case, the patient has paired brachial veins surrounding the brachial artery. You can see the median nerve sits right over top of the brachial complex. Sometimes we still have to go for it because it's better than the risks of a central line. But just one more reason why the brachial vein is a little bit more complicated. The only complications we've seen with our ultrasound guided IVs, I wouldn't say, but the major complications we've seen with ultrasound guided IVs in the ED are brachial sticks on patients who are taking anticoagulation, where one was a pseudoaneurysm where they hit the artery and then hit the vein and created pseudoaneurysm. And then the other was a hematoma that compressed the median nerve, and the patient had about 3 months of numbness in the median nerve distribution. But the basilic's just hanging out, superficial, usually a little bit larger. Great target. This is what it would look like in long axis, sitting right on top. The IV therapy folks have asked us to, if possible, take a look in the forearm and the AC fossa and work our way proximal, just to save those veins for PICS if possible. But typically these have been stabbed a fair amount, so not a great target. And I would certainly say if you haven't completed 10 sticks yet and you don't feel great about your procedural technique, the AC fossa can be technically challenging just because the vessels are kind of merging and diverging a bit. So get a few confidence boosters with the basilic and then work your way to some of the other locations. So just want to talk about two different approaches to really any venous access. Can be helpful for your central venous access as well. So the first is going to be long axis. It's what we're going to see on our ultrasound machine, and the other would be short axis. You're just going to see, that round vessel. Typically, show of hands, short axis people here. Yeah, so most of us start short axis and say that's going to be the home base. You always want to find your vessels with short axis, compressing to make sure it's a vein. But again, the key is following the needle tip to know where the sharp end of your needle is, and that can be challenging in the short axis view. You always want to scan ahead. So the way I've started describing it is more like kind of the waltz, where one foot goes ahead and then the other follows behind. One foot, then the other. But ultrasound probe is always out in front of the needle. And that's how we know that that's the tip of our needle, is when we don't see anything and then the needle comes into view. Otherwise, I could be scanning anywhere along the length of the needle. So needle tip comes into view, and then I scout ahead, advancing the probe forward, and then the needle comes forward, comes into view. You'll be able to see the vein collapse and then pop through. I do recommend, once you're in the vein, laying the needle down and advancing with the needle in the center of the vein for a while, just to get a little more needle and catheter inside the vein. And then I typically take the tip of my needle about 3/4 of the way down into the vein, just to make sure that catheter is fully in the vein. So scouting ahead, needle tip comes into view, and then I advance the probe forward. So needle tip comes into view right there. And then I scout ahead with the probe, and then I advance further with the needle. So scouting ahead, and I know that's the tip of my needle because it was out of view and then came into view. I'm taking it about 3/4 depth into that vein. So really looking for that ultrasonic flash. So the needle tip, especially where it's beveled, will get really bright when you pop into the vein. Fluid's a really good conductor of sound, as I'm sure you've heard a lot this morning. And so you're just going to get that reverberation artifact from the hollow bore needle more prominently when you get inside the vein. Don't bother looking at the flash in the well on your catheter, because that can set you up for a little bit of failure. We'll talk about that in just a second. So get that real bright reverberation artifact when you get inside the vein. Big advantage of short axis is I know if I'm missing right or left, and I can readjust. The big advantage of long axis is I know exactly the depth of my needle throughout the entire procedure. So the key with long axis is I'm going to move my probe over the vein, and then my left arm, left hand, resting on the patient is locked in. It doesn't move. Only the needle moves from here forward. I'm going to try to line up my needle with the vein, with the ultrasound probe. I know the ultrasound probe's lined up with the vein. So if my needle's not lined up with my ultrasound probe, it's not lined up with the vein. So I'm just going to move my needle until it's lined up with the probe and then advance. And so that probe stays nice and still, and then I advance my needle and catheter. Still can see that vein collapse, and then pop in. This is what it looks like real time. Taking it about 3/4 depth down into that vein. Yeah. This is a real small target, and so I'm closely watching the depth of my needle, taking it towards that back wall, making sure both needle and catheter are inside the vein, and then advancing. You can see the catheter advanced into the structure. So pluses and minuses to both. Long axis, you always see that sharp end of your needle, and so you have really good depth control. It's a little more technically challenging. It's easy to slide the probe side to side and lose track of where your needle is. Where short axis is a little easier to get aimed towards the vein, and seems to be the starting place for most people. A little more difficult to be exactly sure where the tip of your needle is. I actually like a hybrid approach. So especially for those small targets, starting out in short axis, get down to the vein, I'm kind of knocking on the door of the vein, and then I rotate into long axis and advance my needle into the vein, lower the trajectory, and advance a little bit further. And I have that excellent depth control at the end of the procedure. So I get the benefits of both at times. If it's a big vein, and it's easy target, I just stay in short axis and pop in. It's not a big deal. Just a couple of real quick things about putting in IVs, since we don't as physicians do that very often, and we don't have nearly as much practice as our nursing colleagues. So I've alluded to this quite a bit, but the needle and the catheter start at different places. So I need to get both needle and catheter inside the vein. So whereas with an art line, I just get the needle in and advance the wire through, same with the central line. Here I need to get both needle and catheter inside the vein. And if you haven't had an issue with this, you just haven't done enough ultrasound guided IVs yet, it will happen. Just be mindful of it. So here you can see that the needle, we have flash within the well of the catheter, but our catheter itself is not in. So if you try to advance, it just bounces off. So that's why I take needle and catheter, or the needle, as close to the back wall as I can, usually about 3/4 of the way, just to make sure catheter's in. Some real quick words of wisdom, just some experience items of having done a lot of these that will be helpful. Same with any procedure you do, whether it's a thoracentesis, a central line, intubation, setup is crucial. And this is no different. Pump up the bed, get it to a height where you're comfortable, make yourself comfortable, make the patient comfortable. A lot of times we're asking them to externally rotate. Our older patients all seem to have some shoulder arthritis, and so it's uncomfortable position for them. As much as you can, make them comfortable, maybe even try putting their arm up behind their head so that they're externally rotated. Rest their arm on a bedside stand. Otherwise, they start moving around, or I'm bent over, trying, not seated, or just, and my back starts to hurt, procedure starts to get a little difficult, then it just unravels quickly. So 90% of this procedure is set up, and just make sure we're doing some. Wipe down the probe. Never know what the last person did right before. Let's try to keep this program going. This hospital has become very reliant on ultrasound guided IVs. And we don't want to have this back. Yeah. It's kind of wild. When I first started, we would do 2 to 3 a week in the ED, and now there's 10 to 15 a day, I would say. Use the longer catheters. They last longer. They show up a little bit brighter on ultrasound. Make sure if you're using gel, use the sterile lube packets, not the lube that's used 1,000 times. And my preference would be, we now have special ultrasound guided IV probe covers to use those. I don't know what the adoption is in the ICU. We're asking our folks to use them. Basically, JCO is suddenly very interested in anytime we're doing procedures with ultrasound where the skin is poked. And they're threatening to require high-level disinfection after every procedure, which would mean sending the probe down to radiology and having it come back, which would be very expensive for the hospital and just a pain, let's be honest. So hopefully we can bypass that by keeping the probes covered. So for our next visit, we can just say, hey, yeah, we cover our probes with these. The covers actually come with this saline solution. It dries fairly quickly. So this is your first 10 times doing this. I'd recommend using gel, but once you become skilled at the procedure, it's nice because it dries quickly and you can adhere the tegaderm more easily and without all the gel, and it's cleaner. So ask your charge nurse about them and see if you can get them up in supply. I know the hospital is supplying them across the institution. So yeah, just highlighting the 2.5-inch catheters. These green ones last longer. So, all right, we can get set up to start scanning here. I think the last little word of wisdom, try to find a vessel that's a good target. Between 0.5 centimeter and 1.5 centimeters is the sweet spot. If it's too shallow, you don't have any runway to land the plane. So you need to be able to see where your needle's going before it enters to get it in. You want to make sure it goes straight for a couple centimeters, and 3 millimeters in diameter is a decent target to be able to thread a catheter. So any questions on that? I was kind of abridged a little, but let's practice and feel free to ask questions and we can clarify the techniques here.